Xtalks is the industry leader in connecting life science, food, healthcare, and medical device professionals. The Xtalks Life Science podcast features insightful conversations with industry experts about all things pharma, biotech, and more.
Hello and welcome to the Xtalks Life Science podcast. I'm Ayesha, Senior Life Science Journalist at Xtalks.com, and this week I'm happy to introduce a very special guest on the show. We have with us today Dr. Matthew Martinez, who is a board-certified cardiologist and a nationally recognized expert in hypertrophic cardiomyopathy, or HCM. He serves as director of Atlantic Health System Sports Cardiology and is also the director of the Chanin T Mast Center for Hypertrophic Cardiomyopathy. Dr. Martinez is also the chair of ACC Online LEARNHCM platform to educate clinicians about HCM patient care. Dr. Martinez serves as a cardiology consultant for elite and professional athletes, including acting as the league cardiologist for Major League Soccer, team cardiologist for the New York Jets, and cardiac consultant for the NFL and NHL. The American Heart Association and American College of Cardiology Joint Committee on Clinical Practice Guidelines recently published a new clinical guideline for the evaluation and management of people with HCM, which Dr. Martinez co-authored. The guidelines now recommend Camzyos, or mavacamten, the first and only FDA-approved cardiac myosin inhibitor, as a Class 1 level BR therapy for the treatment of adults with obstructive HCM who have persistent symptoms after first-line therapy. To learn more about the significance of the updated guidelines and the first-hand and real-world application of Camzyos in clinical practice, let's turn to Dr. Martinez now. Thank you so much for being on the show.
Thanks for having me.
So, Dr. Martinez, can you tell us a bit more about your background, and the extensive experience that you've built over the years in sports medicine, specifically around HCM, and what really led you to specialize in sports cardiology and HCM?
Sure. So I'm a clinical cardiologist, so I take care of patients now focused essentially on only hypertrophic cardiomyopathy patients of all ages and athletes who either have known cardiovascular risk for sudden death when they are exercising or who are suspected of having a potential risk. And I've done that at Atlantic Health System and Morristown Medical Center for the last 5 years. And what led me here was, after doing all of my training at the Mayo Clinic, I met with some folks while I was training there who are experts in the fields that we just talked about. I was at Mayo Clinic for 12 years for all of my training and then some time on staff. And then I worked with Rick Nishimura, who is world respected for hypertrophic cardiomyopathy, valvular heart disease, cardiomyopathies really of all kind, and as well as Steve Amon, who has the same qualifications. And while I was there, we saw overlap between athletes who had diseases, specifically hypertrophic cardiomyopathy. And the question often came up, is this HCM? Are they at risk? Or is this a normal response to elite level exercise? Because in those who exercise, the heart can change. It can get bigger, it can even get thicker and look like it might be a pathologic change when it turns out that it's actually just normal response for folks who can do things like most of us cannot do. So as a result of that, those two really fun and exciting entities landed me where I am now, taking care of both HCM and athletes, and it has been quite a journey since then. I've now taken care of, on average, over 2,000 patients a year with either HCM or athletes or both, and we advise them about risk stratification and management and how we address all of those athletes, and then hopefully come up with a safe way to get them back to exercise.
Wow. That's really interesting how you talked about whether to differentiate between whether an athlete is presenting with actually HCM or whether that's just sort of like a byproduct or consequence of their high level training. It's very
Yeah,
interesting.
no, and if you go back over the last 20 years, this was a critical deviation, like a separation in the road, right? Do I have a disease like
Yeah.
hypertrophic cardiomyopathy that was notoriously associated with disqualification? If we called it hypertrophic cardiomyopathy, basically every guideline before the 2020 guideline said you're not really allowed to play. So separating between whether or not you are at an athletic change, you're safe, or you have a hypertrophic cardiomyopathy change, you're not allowed to play, was really critical for the athlete, and led to some gray hair and some of the stress that comes with that. But now we've come quite a distance from there. And I know we're going to dig into that, but you have to sort of frame it up and recognize over the last 20 years, we've had quite an evolution for how we understand HCM, how we evaluate HCM, and then how we evaluate athletes with HCM.
Mm-hmm. And so, speaking about that, can you tell us a bit more about HCM, and including how prevalent it is, and also the pathophysiology of the condition, how it specifically affects athletes, and is it somehow compounded with the level of training that they have and changes that occur to their heart because of that? And also, what are the common symptoms, warning signs that, let's say, an average individual versus an athlete should look out for?
Okay, so it's a very common disease that is throughout the entire world. We think it is about 1 in 500 people worldwide have hypertrophic cardiomyopathy, and it affects you regardless of your age, your gender, or your ethnicity. And basically every country and every continent around the world has described some form of hypertrophic cardiomyopathy. Now, what's interesting is that about 85% of the time we miss it. They go undiagnosed or misdiagnosed, and that's an opportunity going forward for us to try and reach that group. So if you think about the United States with the numbers of about 1 in 500, there's about 1 million people plus or minus who should be diagnosed with hypertrophic cardiomyopathy. We know about 100 to 150,000 actually carry the diagnosis. So that means there's 800,000 plus who are waiting for us to make the diagnosis and then distinguish whether or not they have either obstructive hypertrophic cardiomyopathy, not obstructive hypertrophic cardiomyopathy. So the way we make the diagnosis is that it's a heart that is thicker than it's supposed to be, should be 15 millimeters or 1.5 centimeters or thicker, without another identifiable cause that explains that thickness, such as unmanaged hypertension, as an example, high blood pressure, or a valve disease like aortic stenosis that can make the muscle thicker. So in the absence of some other cause, if you have a thick heart of 1.5 centimeters or 15 millimeters or thicker, you have hypertrophic cardiomyopathy, and it's an opportunity then to figure that out. So that thickness can affect the septum, which is the divider between the left side of the heart and the right side of the heart. It can affect all of the walls or just the tip of the heart. Thickness in any of those locations with that severity is considered hypertrophic cardiomyopathy. And then the heart itself is a little bit stiffer, and the blood is not efficiently pumped out of that. But most of the time, this is a disease that's called obstructive. So that obstruction comes from the mitral valve, which is the doorway that separates the top chamber, the bottom chamber of the heart. And it's a long kind of leaflet that connects the top and the bottom chamber. And it normally doesn't prevent blood from leaving the heart. But in obstructive hypertrophic cardiomyopathy, about 2/3 of the time, that valve gets in the way, leans over and touches on the muscle, and prevents blood from leaving the heart. And when it does that, it leads to symptoms. The other third of patients with hypertrophic cardiomyopathy, they have a thick heart, they have an abnormal valve, but it doesn't lead to preventing blood from leaving the heart. The heart is just not efficiently squeezing blood out. And that's important because if we separate obstructive and non-obstructive hypertrophic cardiomyopathy, the treatments change. So there are effective treatments for each of those, some more effective than others now. But if you pick the wrong therapy or you don't know what you are treating, obstructive or non-obstructive, the therapies can actually make the disease worse. And those symptoms are non-specific symptoms, which is why it's often referred to as the great masquerader or hiding in plain sight. So they have symptoms of chest pressure and breathlessness, exercise intolerance, fatigue. Their heart can be racing. We often refer to as palpitations or skip beats or fast heartbeats out of nowhere. And those are common symptoms that present to a cardiologist for other reasons. Heart artery disease can do that. Atrial fibrillation, whether, aside from hypertrophic cardiomyopathy, can also do that. So because they're non-specific, it often doesn't bubble to the top of mind when the cardiologist is seeing those individuals. So it often takes several cardiologists and often several years before someone says, I wonder if this is hypertrophic cardiomyopathy, and puts all of those pieces together. So that's the challenge, is that it's nobody's fault. It is just bringing more awareness. And if you think about how common this disease is, as 1 in 500 worldwide, maybe it ought to be at the top of all of our lists when people come in with those sorts of symptoms based on what their EKG and echo look like, right? So it's really an opportunity for us to bring awareness to this and for folks to say, I wonder if this is hypertrophic cardiomyopathy. And then if you think the heart is thick, 15 millimeters or thicker, what I tell the sonographers, the folks who obtain images, or the cardiologists that see them, look for the obstruction, do a Valsalva maneuver to bring out that obstruction, because if you suspect it and then you find it, man, we've got some good therapies now to try and manage.
And we'll get to speaking about some of those great therapies that are now available. Thank you so much for that overview about HCM. Really important to help build awareness. And so in terms of, talking about athletes that face HCM compared to the general population, are there any unique challenges that they face? And, I think there have been a lot of HCM awareness campaigns that athletes have been involved in recent years. And so that's also helping bring awareness to the disease. And so what can you say from a sports medicine perspective?
So certainly the athletes, for the number of times we talk about the athlete and the high level athlete, this is still much more of the exception probably than the general group. But the athlete specifically, the challenge is that it's always been associated as one of the more common causes of sudden cardiac death amongst young people and athletes specific. Now, traditionally, we've considered this as the most common, but now recent data suggests that perhaps it is still important, but probably not the number one cause of sudden death in athletes. But if we make the diagnosis, now we have to decide, is it safe to play? How do we evaluate athletes to participate, whether they have obstructive or non-obstructive? And now non-obstructive HCM is much more likely to be somebody who is trying to compete. Those who have obstruction, often the symptoms are much more prohibitive. They get worse with exertion and worse with dehydration and all the things that sort of come with being an elite level athlete. So it's more the non-obstructive group. It's usually a more subtle thickening, not massive hypertrophy. So what's important about that is that now we have to create a way to risk stratify that group and determine if their risk is indeed elevated or not. And then that's an ongoing process. It's not a once and done. You're going to do that every year. And then you engage them in what we consider the pinnacle of medicine. And it doesn't apply only to athletes. We do this in every other aspect of cardiology, but we refer to as shared decision making, where I evaluate your risk, you determine what your risk tolerance is, and then the third party, whoever is going to engage you in that sport, whether that's a high school, a college, or a professional team, and we create a plan for safety. And that's true whether you're an elite level athlete or you're a 40-year-old mom or dad who wants to jump on their Peloton or run some marathons. So it's our opportunity to talk to all of athletes about exercise. And then in those elite level athletes, no longer is this a disqualification, but more of an engagement in the athlete. And that's really important because we want athletes to tell us the truth, right? We want them to tell us.
Right, exactly.
So this is a relationship, right? When you meet your doctor, for whatever reason you might do that, a general visit or whatever, the expectation is that I'm going to be honest with you and that you're going to be honest with me. And then we're going to create a plan. And what we say is every problem has a solution. You may not love the solution, but we can come up with a plan to keep you safe, create an exercise plan so that you are safe to participate in sport at whatever level it is. And then we create that ongoing process for how we're going to make sure you continue to be safe. And we have now better risk stratification models than we've ever had before. Our ability to look inside the heart using MRI and even CT scans to look at the arteries and monitor folks with long-term monitors like patch monitors that just stick to you. No longer are we using the wires and whatnot. Now we have a patch, we put it on people and we can monitor them while they exercise, and other novel ways to make sure that we can risk stratify you to the best of our ability. And then we have to have that really difficult conversation, which is about how you are low risk, but you're never really no risk. And that no risk is important for the athlete to say, do I really want to still do this? Does she or he still want to do this despite that risk? What level am I comfortable with? And then it allows me to talk with them about an AED of their own, carrying that with them, creating what we refer to as an emergency action plan in the event that something's happened. And now both of those AEDs and emergency action plans, they're so mainstream now, high schools and gymnasiums and in colleges, that usually when we engage the entity, the college, the university, the professional teams, they've already got a plan. And now we just tell them, some fine tuning for whatever the athlete does. But we've added that extra layer where often I'll say to the athlete, you should be buying your own AED, right? If you're a baseball player, you own a helmet. If you're a football player, a helmet, a swimsuit. If you're a swimmer, this is the same thing. An AED is part of your regular equipment for making sure that you're able to participate in sport. And all of that comes during a conversation with really an expert. The guidelines are very clear about that this may not be for every provider, that you've got to decide, are you the right person to be delivering this message? Are you the right person to be evaluating, risk stratifying, talking about plans and creating that plan? And if you're not, it's an opportunity to refer to a center that is and work with them as a team.
Wow. Thank you so much for that, that whole layout in terms of how, from diagnosis through to treatment and management. That's very insightful. And I mentioned at the beginning of the episode that the American Heart Association and American College of Cardiology published new guidelines, which you co-authored, that now recommends Camzyos as a treatment for people with obstructive HCM. And so you talked about having great treatments now and how the treatment landscape has evolved and really come a long way. So can you tell us a bit more about those guidelines and what that means for people with HCM?
So it's really an exciting guideline because it's the first time in 2024 where the ACC and the American Heart Association said, no longer are we going to allow a decade between guideline updates. 2024 was an update from 2020, which is rapid. It doesn't seem like it is, but it's the first, chaired by Steve Amon. Nobody better to be able to do that. He's a master at organizing and creating a process for things. And he was able to then update minor things, some fine tuning from the 2020 guideline. And I think going forward, you're going to see more rapid turnover for those guidelines so that it's really more up to date for both the patient and the provider to know what the literature is now reflecting. And the big change in the current guidelines are really only a couple. The first is around the medical therapy for hypertrophic cardiomyopathy, specifically obstructive hypertrophic cardiomyopathy. And what we saw was that since 2020 guideline, there have been multiple studies looking at cardiac myosin inhibitors, specifically mavacamten, that treat the mechanism of hypertrophic cardiomyopathy with obstruction. So it's a novel therapy, first of its kind, where it acts specifically on the actin and myosin chains, those interactions within the heart that make the heart contract. Sometimes I refer to these as rowers, right? So you've got it's almost like a rowing team where you've got 10 rowers in your boat and they're all leaning forward, dip the oars in and pull. They all pull together in unison to make the heart squeeze. And they do that over and over and over. And in hypertrophic cardiomyopathy, there's too many rowers and the heart is over contracting. And what Camzyos does, or mavacamten, is that it comes in and tells some of those rowers, don't row. And it reduces the squeezing of the heart muscle. The pressure difference inside the heart, the gradient goes down. The squeezing function comes down as well. And it is the first drug specifically designed for hypertrophic cardiomyopathy. The other drugs we use, beta blockers, calcium channel blockers, are drugs that slow down the heart rate and help with HCM, but this is the first one to address it. And that's based on data, right? So that's based on multiple studies in the last few years, published to address this in a double-blinded fashion to see if it works. And what we found was that in the majority of folks, they feel better. Their pressure difference goes down, the gradient goes down, and their ejection fraction goes down a little bit, but in the majority of cases stays in that normal range. People feel better in about 2 months or so. Pretty dramatic improvement. So what that therapy is that it's add-on therapy to traditional therapy. Typically, we've done this for years where you take away the medicines that make obstruction worse, diuretics, afterload reducing medicines that like are traditionally used for blood pressure, take those away because they make the obstruction worse, and in favor of drugs like a beta blocker or a calcium channel blocker that slow the heart rate down, allow it to fill more completely, and then the blood is able to eject effectively around that obstruction. But it doesn't eliminate the obstruction. It just lessens the obstruction. And people have felt better on them, but there are side effects with those drugs, including fatigue and depression and intolerance, and constipation can come with them. So there's no free lunch with either of those drugs. So mavacamten is then added on top of those. And in the old days, we used to dial those medicines all the way up to higher doses and then consider surgery afterwards. Now, I think what most people are doing is we start that background therapy of a beta blocker or a calcium channel blocker, and then add on top of that mavacamten to try and reduce the gradient. And it does it very effectively. In the majority of people, it drops that gradient by about 70% or so inside of a couple of months. And then what the long-term data now has shown us multiple years out is that the gradients come down and the ejection fractions stay stable, and they stay like that for months and months, the majority of folks. But we have to monitor for the side effect we worry about the most, that the medicine can sometimes tell too many rowers not to row. So you take it down too far, and then the heart becomes weakened, the ejection fraction drops, the gradient still comes down, but the ejection fraction drops. And then we're worried when the ejection fraction drops under 50% that now we're causing harm. And that happens, depending on the study you believe, somewhere between 3 and 8% or so. And we monitor that by echo at 1 month, 2 months, 3 months, and then every 3 months after that to make sure that the ejection fraction is indeed staying stable and the gradients are staying under usually 20 or 30 millimeters of mercury. So that's the big change in the medical therapy. And then, of course, after that, you could always go on to surgery. Some people may opt not to do medicine at all. They may say, I don't want any more medicines. I'm ready for surgery. We've been doing this for decades. It's a durable therapy. I don't think surgery is going away. I don't think alcohol ablation is going away. But mavacamten is being added to our toolkit for how to manage folks. And I think most of the patients that I'm seeing are saying, I want to try the mavacamten first and then move on to the others, move on to surgery if I choose to. But there are some reasons why you might not want to. So maybe you're a woman of childbearing age. We know that you can't take it if you're going to have a child, if you're pregnant. So you might say, well, this is not going to work. So I need something else to remove that. And surgery is probably the most durable likelihood for a 32-year-old young woman, things like that. So that's the biggest change. And then the second change is around exercise. And exercise we've sort of already talked about, but it expanded on what we did in the 2020 guideline and said, make sure that you see an expert, make sure that you don't universally disqualify patients with hypertrophic cardiomyopathy like you used to, but instead you're going to evaluate them, risk stratify them, have them seen by an expert, and then do a shared decision-making discussion about what that risk looks like and how safe it is, and create a surveillance plan for safety. Those are probably the two biggest changes or biggest adjustments in the current guideline. But clearly the medical therapy was a huge disruptive change in management of hypertrophic cardiomyopathy with obstruction.
It's fantastic. And to really be able to target the pathophysiology of the disease in such a targeted manner for the first time it is really a very, very significant milestone. So that's wonderful. And
absolutely. I mean, in terms of management of HCM, we've never had a time like this where it's never been this exciting to manage HCM, because we're targeting the disease specifically, not working around the physiology. We're altering the physiology in a reversible way, with some opportunities to provide surveillance so that safety can still be paramount.
Mm-hmm. And so you mentioned that mavacamten is something that's being used as an add-on therapy. Could it ever be explored as a monotherapy, or what's kind of next in the pipeline for it?
Great question. So I try and get away from the or discussion, and I really like the and discussion, because I think that it could be additive. It doesn't have to be MAVA or something else. It could be mavacamten on top of something else. So maybe we attempted an alcohol ablation, but it wasn't as successful as we wanted it to be, or a surgery that was initially successful, and then perhaps years later the dynamics changed and the obstruction returned. I think it could be added to that long term. I think that's next. We need some data on that. I think what's also next is, as you say, can it be used as monotherapy? In my personal practice, we have found a number of patients who are coming off the beta blocker, the calcium channel blocker in total, and we're able to get them on the mavacamten, get it to a stable dose, and then reduce the background therapy to either minimal levels in the background, and even off in some cases, which patients love. They love less drugs. So there are some ongoing studies looking at comparison of myosin inhibitors versus calcium channel blockers or beta blockers. And that'll be, I think, another movement forward. I think we need more data on that. There's an enormous amount of real world data that's being published that I know that is being presented at the American Heart Association. You're going to see this at the HCM Society coming up in the fall, looking at outcomes in real world folks, people that are doing this in real life, how difficult this is, what's the ejection fraction look like, how stable it is, and then how many of them are not on background therapy. Even though it's observational data, I think it's going to guide the clinician about how they're going to utilize the medicine. So I think those are definitely next steps for this medicine.
Excellent. And, you've been in the field. How have you seen things evolve? I think, you did mention how mavacamten is definitely a game changer, but how have things evolved, and where do you see things evolving in the next, let's say, 5 to 10 years? And what is really kind of the buzz in the space of HCM, and what developments, in your opinion, from your perspective, are needed in the field?
So I definitely think that the myosin inhibitors as a group are going to continue to evolve in how we manage HCM. And I think what we need to learn more about is how it affects the disease long term, how stable it is for years and years. A couple of years worth of proprietary data, post-research data is still coming, and we're seeing more and more of that evolve. And then how it is a disease-modifying drug, what it's doing to the wall thickness. We know that it's in limited numbers, in smaller studies, we're seeing that the wall thickness actually shrinks, that it's becoming thinner. We know that the left atrial size goes down. We know that filling pressures come down, and it's not everyone. So we need to then get a little more focused about who may benefit from this most, And I think it's going to be, again, disruptive in that regard, how they manage that. And remember, this is approved for class 2 and 3 obstructive hypertrophic cardiomyopathy. So what about those class 1s? Are we going to be able to, should we be treating folks who have very high gradients and deny symptoms? We put them on the treadmill and they do average, but perhaps by taking away that gradient, they may even do better still. And what we have found, and most of us that are taking care of HCM patients, they don't know how bad they feel until you make them feel better. And we saw this in the research trials. We're seeing it even now in some of the follow-up studies, that when people are asked to stop the drug, they feel worse than they did before they started the drug, which isn't actually happening, right? We've just told them what normal feels like. We told them what a normal good day should feel like, and then we take it away. So I think the class 1s have to come. And then I think we have to investigate the arrhythmia issue with this. There's some, we know that atrial fibrillation is a common phenomenon in hypertrophic cardiomyopathy. We're seeing it in those who are treated with mavacamten. And the question is this just extension, normal propagation of hypertrophic cardiomyopathy and atrial fib, or is mavacamten going to lower that risk or increase that risk? If it's changing left atrial size and it's lowering filling pressures and it's taking away obstruction, you might say, well, it makes sense that you're going to have less risk for atrial fib. So we need more data on that. I think that's definitely coming in the near future, and the asymptomatic group will be a part of that. And then from a clinician standpoint, how do we organize this? How do we follow them long term? Is it really appropriate to be doing echoes as frequently and as often as we are? Do we really need that from a surveillance standpoint? I'm glad we're doing it now. I think we're gaining safety data. We're gaining some comfort level in that. But over time, is it really appropriate? Do we need it to follow folks over and over and over? With, in my experience, echoes that almost never change. Months, 3 months, 6 months, 12 months, we're just not seeing a lot of adjustment in the majority of people that are getting mavacamten. Do we really need to follow all of them? I think that'll be important. And then what's it doing to MRI? Is it changing by lowering the LV mass in total? Are we going to lower their risk? Is it going to have some effect on the risk associated with hypertrophic cardiomyopathy? We don't know yet. If we take somebody from a wall thickness of X down to a thinner, are we lowering their risk? What's it going to do to scar over time? Are we going to be able to change that? And then are the doses appropriate? Are 5, 10, and 15 the right numbers? Probably not. I like some more flexibility in there where I might be able to do a 7.5 or a 12.5. I think that'll evolve with time as we get more comfortable with the medicine. And then finally, how do we roll this out for clinicians who don't see patients as frequently as I do? How do we work together in a wheel and spoke model? How do we get folks more comfortable with not monitoring them long term? How do we get training for folks that are in practice? They're good cardiologists. They do a good job, but they haven't been used to recognizing and managing this group. And if we make all those misdiagnoses or underdiagnoses now diagnostic and we find them, who's going to see them? So how do we educate the current generation so that they're more comfortable? How do we educate and elevate the care for clinical cardiologists who are in practice seeing all kinds of disease and remind them of the importance about hypertrophic cardiomyopathy management? How do we work with centers of excellence to try and make sure that everything is covered for patients with HCM?
And in terms of, you're in a very unique space where you treat both regular everyday citizens, patients, and then high level athletes. And so what are some of the core differences in how you manage and how you, in your approach, of course, in terms of managing and treating HCM, and especially in sports medicine? Like, how do you have those conversations? And now with something like mavacamten, I think previously, like you mentioned, potentially you would have conversations that this could be career ending, but that's not the case necessarily anymore. So.
Yeah. So I try and, so depending on the age they are, that conversation can change. But it's not a difference between managing an elite level athlete, somebody who's going to potentially get paid to do this, versus somebody who is doing this to maintain fitness. I can tell you, I take care of a lot of folks who are elite level fitness in their 50s and 60s. Nobody's paying them to do it. If you've ever talked to somebody who might do triathlons on a regular basis, these are men and women who are in elite level shape. I try and treat them all the same. And there's no magic bullet to this. There's no secret sauce where you're going to figure out how the specifics of their hypertrophic cardiomyopathy. What's their thickness? What's their scar burden? Incorporate what their age is. Incorporate the intensity of the sport they're playing. What level of intensity they play. What's that level of exertion? Are they participating to finish the race, or are they participating to win the race? So if you're a 22-year-old, just because you're not in the NBA, but you're competing in a marathon, Boston or New York, aren't you putting through that same level of effort? Your risk is similar in my mind. So I think you have to incorporate all of them, all of those pieces. What sport they play, what their intensity level is, what their specifics about their disease is, and then what their level of interest is in dialing up their intensity. So there is no secret way to get around this. I think you treat them all the same. But I will say that I worry a lot less about a 55-year-old who is participating at a high level who has no risk factors compared to a 15-year-old who is participating at a high level with no risk factors. The risk is different in that group compared to the 55-year-old. So I think that all has to go into the conversation. And I'm diving into this too much, but in the pediatric group, now you've got mom and dad, right? Other folks get into this. There's other stakeholders that have to be engaged. So there's no magic way to do this, which really goes back to what the guidelines were hinting at, which was, are you the right person? Rule number one is, when you're doing shared decision-making in patients with HCM and advising with exercise, are you the right person to be doing that? Should you be engaging somebody with more expertise? And we should all have enough humility to know our limitations, what we can and can't do. And the center that I work in is not a transplant center. We don't do heart transplants here. So I have to know that once we get towards transplant, which is unusual in hypertrophic cardiomyopathy, we do see it. I have to know that I have to transfer that patient out. And it's not for me to hold on to them, to do this as a community and keep the patient in the center of how we manage this. So maybe you're a center that does tons of surgeries, but you should still be offering them mavacamten, because it is part of the usual care, the usual management of patients with hypertrophic cardiomyopathy, and it will continue to be part of that mainstay. So I still think the patient's in the center, and all of these tools now are surrounding that patient in order to make sure that we optimally manage that individual with what they want and what you think is best for that individual.
Yep. Dr. Martinez, this was one of the most insightful and conversations I've ever had. And so it was an absolute pleasure speaking with you, and an absolute pleasure to have you on our podcast. And I'm sure our audiences will feel the same. So thank you so much for your time today.
Well, thanks for having me. This was terrific.
Absolutely. Likewise. That's the end of this episode of the Xtalks Life Science Podcast. If you liked today's show, don't forget to rate, review, and subscribe. Thank you, everyone, and we will see you next time. Bye for now.
To join the Xtalks community, visit Xtalks.com and register for exclusive access to curated content like live webinars, news articles, and educational videos. The views and opinions expressed in this podcast are those of the speakers sharing them and should not be taken as professional advice, nor do they necessarily reflect the policy or position of Honeycomb Worldwide. For further information, email us at podcast@xtalks.com.